for showing up and joining the meeting. For those who come later or will come later, the recording will be on the app. Thank you. And Dr. Slafa will lead the meeting.
Okay, hello everyone. We have 3 topics to present today, and I would like to start with Lubaba and Malaz. So please feel free, Lubaba, to share your screen and start your presentation. Thank you.
All righty. Thank you so much. Good afternoon, everyone. Good evening. Assalamu alaikum. Let me share my desktop. Do you see my screen?
Yes, Lubaba, we can see it.
Okay. Yes. I'm just wondering, does the view of the attendees blocking you? Because I see that in my end. Or do you see the screen? Okay, perfect. So today we're going to talk briefly about hypertension updates that came recently. I believe on August 25th or something, there were a new article with updates regarding management of hypertension and how we approach hypertension. So we're going to shed some light on that. Our objectives today is going to be introduction and overview, and diagnosis updates and management updates and recommendations. We're not going to talk too much about the clinical part of hypertension since we are a research kind of program. So introduction and overview. Statistically, we are talking about 1.13 billion worldwide with hypertension. 1 in every 4 men and 1 in every 5 women. By 2015, they were diagnosed with hypertension, and unfortunately, less than 1 has hypertension controlled. Hypertension is known as high blood pressure or is a serious medical condition and can increase the risk of heart disease, brain, kidney, and other diseases. And it's one of the leading causes of death globally. And one of the up to 30% of myocardial infarctions are actually responsible for that is hypertension, in addition to 8.5 million deaths from stroke, ischemic heart disease, other vascular diseases, and renal disease worldwide. This is based on WHO. So recently there was a study completed on 2019 done by Global Network of Physicians and Researchers, covered the period between 1990 and 2019, where blood pressure measurement and treatment data from over 100 million people aged between 30 to 79 years in over 180 countries gathered, covering 99% of the global population. This study was funded by the WHO. This study revealed that hypertension has increased from over 60 million to 1.2 billion in the last 30 years. This is a huge jump in this disease. And the study also revealed that the burden of the hypertension is most felt disproportionately in low and middle income countries, where 2/3 of these cases were found, largely due to increased risk factors in those populations in recent decades. The study also showed a significant gaps in diagnosis and treatment, where over 500 million or 580 million people with hypertension were unaware of their diagnosis because they were never diagnosed before. So about 40% of women and 51% of men were hypertensive and unaware of their diagnosis. So what are the updates that we need to focus on and how we can tackle this? So although it's straightforward to diagnose hypertension and relatively easy to treat the condition with low-cost drugs, the study revealed that significant gaps in the diagnosis, as I just mentioned, where nearly half of the population are unaware of their condition and they were never diagnosed. So due to the variation on the blood pressure measurement, reading based on the measurement techniques and diagnostic criteria are specific to the technique that's used. Medically, or the clinical approach of the diagnosing hypertension, for example, medical history, it's most of them they're asymptomatic most of the time. However, some specific symptoms can suggest secondary hypertension or hypertensive complication that requires further investigation. So that means the primary providers are required to do a complete medical and family history is recommended, and family history of hypertension or premature cerebrovascular disease or hypercholesterolemia, etc., are most of the risk factors that can direct clinicians to diagnosis. In addition to that, for the clinical approach, definitely a physical examination, thorough physical examination that's needed to assess to confirm the diagnosis of hypertension and identify any other hypertensive mediated organ damage or secondary hypertension. Other things are the laboratory investigation and imaging techniques, and for example, cardiovascular techniques and images like ECG, echocardiology, and Doppler ultrasound to assess, especially for young women. A lot of interesting cases that I came across with unfortunately malignant hypertension diagnosed at the beginning, just even with the Doppler ultrasound, this thing in the renal artery stenosis or something like that, and ended up being a malignant hypertension, but essential hypertension with no other. So imaging techniques is definitely needed when you suspect any complication of secondary hypertension or even essential hypertension. So as I mentioned earlier, there is, based on the techniques used and the location actually, there is some threshold set by the guidelines. This is the thing that's mostly updated. So this is based on a 2020 article that is published in regard to this and referenced by WHO. So at the office level, the threshold is 140/90. At home is 135/85. This is considered at hypertension. 24-hour ambulatory monitoring, it's 130/80, and average. Daytime average is 135/85, where nighttime average is 120/70. So the home measurement are really used, I think, to avoid the white coat hypertension and any other confounding readings that can affect the measurement at the office. On that note as well, so office-based tests need to be repeated like 1 to maybe 4 times visits, or 2 to 3 times visit to the office to confirm the diagnosis when it is the first time to capture hypertension. So as we know that hypertension has like 2 grades. So grade 1 hypertension, or that's diagnosed when the blood pressure is less than 160/100 millimercury, where any higher readings other than 160/100, providing that is the repetitive reading, it is considered grade 2 hypertension. And this is, my colleague Malaz will talk about more the importance of that in the management and treatment. In addition to that, a single blood pressure reading measuring 180/110 accompanied with evidence of cardiovascular disease, this is requiring immediate treatment and considered diagnosis of hypertension at the spot. Patient should be reassessed every 1 to 4 weeks to confirm the blood pressure elevation. So now the management updates and recommendation. I'm going to shift gears to another PowerPoint, and sorry for the technical issue my colleague Malaz faced earlier, but she will be continue from here. Malaz, do you see my screen?
Yes.
Yes.
Hello, everyone.
Take it from here. Thank you.
Okay. Thank you, Baba. Okay. I will carry on managing how to manage or how to approach patient with hypertension. Okay. Firstly, we will talk about lifestyle modifications, and secondly, we will talk about pharmacological treatment for hypertensive patients. Um, for lifestyle modification, healthy lifestyle choice can prevent or delay the onset of high blood pressure and can reduce cardiovascular risk. Lifestyle modification also considered as first line of treatment of hypertension. Modification in lifestyle also can enhance the effect of antihypertensive treatment. So it's considered as first line treatment, and it can help in the second line treatment. Um, when we talk about lifestyle modification, we are talking about DASH diet, which is dietary approach to stop hypertension, which is dietary pattern consistent with high fruits, high vegetables, would be rich in magnesium and calcium, and low in fats and low in sodium. This will subsequently reduce the blood pressure. Also, we are talking about reducing weight, we are talking about exercise and smoking cessation. We will see it later in diagram. Pharmacological treatment, uh, it's important because difference in blood pressure of about 20 over 10 millimercury is associated with a 50% reduction in cardiovascular risk. Just if we will make a difference of 20 over 10, we will reduce the cardiovascular risk with 50%. That's why treating hypertension is very important to prevent the associated complications. We have in treatment essential standard of care and optimal standard of care. Optimal standard of care, this is the best result can be achieved according to the evidence-based guidelines for patients whose age is 65 and less. Our blood pressure target should be less than 130 over 80 if tolerated, but it should be more than 120 over 70. And for patients whose age more than 65 years, our blood pressure target should be less than 140 over 90 if tolerated. But this target should be individualized. Okay, our aim should be reached within 3 months. Essential standard of care. Sometimes we cannot achieve the optimal standard of care, which is the best standard of care, and we will shift to essential standard of care, which is the minimum accepted result. We should target blood pressure reduction by at least 20 over 10, and ideally, we should keep the blood pressure less than 140 over 90. Also, we should reach this goal in around 3 months. Okay, if we establish the diagnosis of hypertension, what we will start with, firstly, we will start with lifestyle adjustment or advice, and then according to the blood pressure reading, if we confirm this is hypertension, we should classify it as grade 1 or grade 2, as mentioned by Lubaba before. Grade 1 blood pressure ranging from 140 to 159 over 90 to 99, which is less than 160 over 100. We have essential and optimal standard of care. We will start immediately medication or antihypertensive drug for those with for those high risk patients. Patient hypertensive with cardiovascular disease, with chronic kidney disease, with diabetes, or any hypertensive mediated organ damage. Optimally, we can start the treatment in low to moderate risk patient, even without cardiovascular disease or chronic kidney disease or diabetes or hypertension mediated organ damage, after 3 to 6 months of lifestyle intervention. So we will start with lifestyle intervention. We will check after 3 to 6 months. If there is no response, we can start the antihypertensive treatment. Essential standard of care, if we have limited drug availability for those at low risk, we will start also by lifestyle modification for 3 to 6 months. If still the blood pressure high or not controlled, we will consider adding drugs for those who age 50 to 80 years. Okay. For grade 2 hypertension, which is blood pressure reading more than 160 over 100, we should consider immediately starting antihypertensive drugs, along with also lifestyle modification. Oh, this is not that very obvious. Huh? I will try to give you a quick idea about this diagram. Okay, we confirm that we have hypertension. This discussed before by Lubaba. We will see this is stage grade 1 or grade 2. We will evaluate by history, physical exams, by lab tests, searching for secondary causes, and like this. For treatment, we have grade 1 and grade 2 and grade 2 hypertension. Grade 1, 140 to 159 over 90 to 99. We will start with lifestyle intervention, as we mentioned. Secondly, this is the first line. Secondly, we will start drug treatment in high-risk patients with cardiovascular disease, with CKD, with DM, and organ damage caused by hypertension, and for those who age 50 to 80. Thirdly, all others with persistent blood pressure elevation after lifestyle modification of 3 to 6 months should be placed also on medication. For grade 2, we will start immediately by drug treatment along with lifestyle intervention. Lifestyle intervention consists of stopping smoking, regular exercise, weight loss, salt reduction or restriction, healthy diet and drink, as we mentioned by that approach, and to lower alcohol intake. Drug therapy steps. This is very important because now we will discuss which drug we will choose. For non-plaque patients, we will start with low-dose angiotensin converting enzyme inhibitor or angiotensin receptor blocker along with calcium channel blocker. This is the first step. If still blood pressure not controlled, we can increase the dose to be full dose. If still blood pressure not controlled, we can add step 3, we can add thiazide like diuretics. And step 4, if still not controlled, we can add spironolactone, or if not tolerating or there is contraindication, we can add amiloride or eplerenone or clonidine or beta blocker. This for non-plaque patients. For plaque patients, the first step, we will start with low dose angiotensin receptor blocker along with calcium channel blocker or calcium channel blocker along with thiazide like diuretic. The second step, if not controlled, we can increase the dose of the previously mentioned combination. And the third step, we can increase diuretic or angiotensin receptor blocker or angiotensin converting enzyme inhibitor. And the fourth step also, we can add spironolactone, or if not tolerating or there is contraindication for spironolactone, we can add amiloride, eplerenone, clonidine, or beta blocker. After starting drug management, we should monitor, we should achieve our target by 3 months, and we should decrease the blood pressure to less than 140 over 90 for those who age more than 65, and less than 130 over 80 for less than 65. We should monitor blood pressure, and we should monitor the adverse effect of the prescribed medicine, and we should monitor for long-term adherence. After all these steps, if still blood pressure not controlled, we should consider referral of the patient to another health provider or care provider with hypertension expertise. We discussed the management, which drug to choose and how to upgrade. Now we will discuss hypertension and common comorbidities and complications and how to choose the medicine in this situation. in hypertension and coronary artery disease. As Lubaba mentioned before, around 30% of acute myocardial infarction attributed to hypertension. So, as we mentioned, lifestyle changes are recommended in form of smoking cessation, diet and exercise. Blood pressure should be lowered if it's more than 140/90, and our target should be 130, less than 130/80. And for elderly patient, less than 140/80. Which medicine we will choose in hypertensive patient with coronary artery disease? Renin-angiotensin system blocker and beta blocker, they should be used irrespective about the blood pressure level, with or without calcium channel blocker, which is already the first line treatment for hypertensive patient. So every patient with coronary artery disease and hypertension should be placed on renin-angiotensin system blocker and beta blocker. Lipid lowering agent also should be started. Our targeted low density lipoprotein should be less than 55 milligram per deciliter. Also, we should add antiplatelet in form of acetyl salicylic acid. We have also common comorbid condition, which is hypertension and stroke, previous stroke. Hypertension, as we all know, considered most important risk factor for ischemic or even hemorrhagic stroke. And the stroke can be largely prevented by adequate control of blood pressure. Our targeted blood pressure also should be less than 130/80 or less than 140/80 for elderly patient. Renin-angiotensin system blocker, calcium channel blocker, and diuretic are the first line drug option in hypertension and stroke. Also, we should use lipid lowering agents, but here our targeted LDL level is less than 70 mg per deciliter. Also, we should add antiplatelet in case of ischemic stroke, but we should not add antiplatelet in case of hemorrhagic stroke. We will move to hypertension and heart failure. Hypertension, as we all know, is a risk factor for development of heart failure with reduced ejection fraction and with preserved ejection fraction. Clinical outcome is worse and mortality increase in patients with hypertension and heart failure. Also, lifestyle changes are recommended in form of dietary change and exercise. Treating hypertension will have a major impact on reducing the risk of incident heart failure and even heart failure hospitalization. Blood pressure should be lowered if it's more than 140/90, and our treatment target should be less than 130/80, but should be greater than 120/70. Also, renin-angiotensin system blocker, beta blockers, and mineralocorticoid receptor antagonists are all effective in improving clinical outcome in patients with established heart failure with reduced ejection fraction, whereas diuretics evidence is limited to symptomatic improvement. Okay, so renin-angiotensin system blocker, beta blocker, and mineralocorticoid receptor antagonist, as we all know, this will have mortality benefit, will decrease the mortality rate, and diuretic just for symptomatic relief. Calcium channel blocker are indicated in case of poor blood pressure control. Also, we have angiotensin receptor neprilysin inhibitor like sacubitril valsartan is indicated for treatment of heart failure with reduced ejection fraction if we cannot use angiotensin converting enzyme inhibitor or angiotensin receptor blocker in hypertensive population. The same treatment can be applied to patients with heart failure with preserved ejection fraction, even if the optimal treatment strategy is not known. We will move now to hypertension and chronic kidney disease. Hypertension considered as major risk factor for development and progression of albuminuria and any form of chronic kidney disease. So lower estimated glomerular filtration rate is associated with resistant hypertension and even masked hypertension and elevated sometimes nighttime blood pressure value. The effect of blood pressure lowering on renal function and albuminuria are dissociated from cardiovascular benefit. Blood pressure should be lowered if blood pressure is already more than 140/90, and the treatment target should be to lower the blood pressure to less than 130/80 or to less than 140/80 in elderly population. In hypertension with chronic kidney disease, a renin-angiotensin system inhibitor considered first line because they will reduce albuminuria in addition to blood pressure control. Calcium channel blocker and diuretic also can be added. For loop diuretic, if the GFR is less than 30 milli per minute, it can be added. In patient with hypertension, chronic kidney disease, we place him already on angiotensin receptor, on renin-angiotensin system inhibitor. Estimate GFR should be monitored, microalbuminuria should be monitored, and blood electrolytes also should be monitored, because as we already know, all renin-angiotensin system blocker or inhibitor will affect the electrolyte in form of potassium level change. Thank you. Do you have any questions?
Thank you so much, Melaz, and thank you so much, Lubaba, for the wonderful presentation.
You're welcome.
Yeah. If anyone please have any question, feel free to type or unmute yourself.
Yeah, just I need to say thank you for Lubaba and Malas for wonderful presentation. Uh, I have one comment on the part of the lifestyle modification. You just mentioned the DASH diet, and I don't know if you intentionally or unintentionally drop the losing blood weight or weight loss is the most important part of lifestyle modification, as I heard that any reduction in the weight by 1 kilogram or 1 pound, I'm not sure, can help reducing the blood pressure by 1 point.
Yes.
Yeah, this is the only comment that I have on this presentation, but otherwise it's an excellent presentation. Thank you.
Thank you. Thank you. Yes, in lifestyle modification, the most important thing is weight reduction. It has a major impact on lowering blood pressure, as you mentioned. Thank you.
Hi, thank you. I have a question. Lubaba and Mela, thank you so much for the nice presentation. My question is about, is there an update about the race-specific modification? Because I'm not sure, but I think I remember about like people from African descent, they are less sensitive for calcium channel blockers or something like that. It has been a long time since my mind is not very fresh, but I was remembering something like that. This like the information regarding sensitivity towards drugs change due to racial factors. Anything about that, if you can remember or remind us about it?
I did not get your point, Hadil. Sorry.
My question is, I do remember there was like in the literature, like the people from African descent, the Black people specifically, they are less sensitive to calcium channel blocker, or vice versa. I'm not sure. They have some like if they got diagnosed with blood pressure, I think there's recommendation for the physician to against use or to not use calcium channel blocker with them. I'm not sure, but I remember something like that. I don't know if you
Okay.
have any information about it. The racial factors in the treatment, I mean.
Okay, I got your point. I will start answering, and then I will refer your question to Dr. Nadir, because I guess this is his field. Here, according to this guideline, they divide the treatment options to non-plaque and plaque. And in plaque patients, they mentioned the first line treatment is low-dose angiotensin receptor blocker, along with calcium channel blocker, or calcium channel blocker with thiazide-like diuretics. So according to this guideline, they are sensitive because it's the first option. But I don't know, maybe there is recent guideline stating against this. So we can be sure from Dr. Nadir.
Okay, thank you, Melas. Thank you so much.
Welcome.
Thank you. Thank you so much, Hadi, for the question. And thank you, Melaza, for the presentation. It's really great. And you brought us up to speed as far as the clinical side. So the question about the race and its effect on choosing what medication, I agree with Melaz that according to certain guidelines, they want to use ACE inhibitor, for instance, or don't start with certain medications. For example, in the past, we used beta blocker as a first line. Nowadays, it's different. There are multiple factors. One of them is a race, but also I think you should think about the patient from other angles, like if they have diabetes, for instance, ACE inhibitor will be targeting the hypertension, and also it will be beneficial in this group of patients. Patient with heart failure, maybe you think about the beta blocker as far as it helps both the blood pressure and the heart failure. So there are certain pathways for you to consider when you are dealing with the initial step as far as how to treat newly diagnosed patient with hypertension. If you have the patient already diagnosed and already on some blood pressure medications, then you will just try to increase the dose slowly to control the blood pressure if it's not controlled. If you reach the maximum or approaching the maximum dose for the medications, then you want to add a different class of medication to control the blood pressure. Sometimes you may succeed, but sometimes you may not be able to. One thing you should think about when you are dealing with patients who are the blood pressure is not controlled, one factor you should think about is the compliance before you adding more medication to the regimen for controlling blood pressure. Because sometimes the patient may not take the medications. Is it because of compliance? Is it because of the price, the insurance? So if they are taking the medication as prescribed, then you can go ahead with adding more and more types of other blood pressure controlling medication. So you do it in a stepwise manner, but it's a good question. Thank you so much, Kadir, for the question.
My pleasure.
Thank you, Dr. Nadir. I want to mention another point also. In geriatric population, in all population, we tend to place them on monotherapy. We are trying to avoid polypharmacy in all the patients, so better to be placed on monotherapy and even single dose for more adherence. And if there is resistant hypertension, patient placed on multiple antihypertensive with optimal dose, and we confirm that he is adherent to his medicine, 3 or more medicine, and still his blood pressure not controlled, we should search about secondary causes. So we should investigate the patient in a good way to see if there is secondary cause of high blood pressure or not. This is also important point. Okay, for this combination therapy in young patients, or also we tend to use dual therapy in single pill. So we can use combination therapy in single pill also to improve the adherence. Thank you.
Thank you so much for the addition. And one thing also you should think about when you're dealing with the pediatric population is the side effects. So when you are targeting the blood pressure, you want to control it, but at the same time, you don't want to overshoot or overdo it. Because one major side effect is the orthostatic blood pressure. And sometimes this might cause or might lead to falls, fractures. So in geriatric, we usually start blaming the medication for anything. So if a patient had a fall, we review the medication. Most likely we'll look at the blood pressure medications. So if he is or she is on 3 or 4 medications, we want to, as Melas mentioned, we want to make sure the patient needs the right medication. So we will modify it according to their needs and minimizing the risk of orthostatic blood pressure falls, for instance. Thank you.
Thank you, Dr. Nadir, for the detailed clarification. And thank you, Malaz and Habil, for your question, Muhammad also. So if there is no more question on hypertension, we can proceed to our next topic.
I think there is 2 hands raised. Sorry.
Oh, sorry.
Yeah, and thank you so much, Dr. Nadir, for the addition regarding geriatric. We were aiming to add that to the topic, but we couldn't find a better resource than giving you the ball to talk about it. So thank you.
That's fine. That's fine.
All right.
Okay.
Thank you.
So El-Hadi, you can go ahead. Sorry, I didn't see the hand raising. Thank you, Luba.
Okay, so thank you for giving me the chance and for this informative presentation. I just have one thing to add, which was a study actually comparing the use of ramipril, I think, yeah, ACE inhibitors in different populations versus the standards of treatment at that time. I think it was 2000. This was a famous study. So it found out that even though ramipril would lower the blood pressure in numbers to a lower degree, but the effects were so good and mortality and morbidity was reduced very much in ramipril population, so that they have to stop the study. They had to stop the study because of that, and these results were significant. So I don't know if this affected the guidelines or not, but the results were actually good. So ramipril or ACE inhibitors were beneficial compared to calcium channel blockers. So I don't know how this adds up to your presentation. So thank you for giving me the chance. And that's it. Yeah.
Thank you so much, Dr. Abdel-Hadi, for your comment. Any comment on his comment?
Thank you for the comment, Dr. Abdel-Hadi. I couldn't hear you very well, but you were saying that the study, when was the study? Actually, the guidelines that, okay. HOPE study. Honestly, I did not come across that study, but the information that we presented based on a recent study globally was done and published on 2020 actually, and the study was running between 90 until 2019. I'm not sure the HOPE study was included in this data or not, but that's something that we can look into it and maybe come with answers to your questions. Thank you. If anyone else heard about the study, please shed a light. Thank you.
Okay, I'm trying to search for this article on NCBI, and maybe we can proceed to Osama while we are figuring out the result of HOPE study. So please, Dr. Osama, feel free to unmute yourself.
Thank you for the excellent presentation. I have like suggestion or comment regarding hypertension in general. So it seems to me that hypertension is very difficult to treat. And if you ask anyone how many drugs do you have, he will say like 2 or 3 drugs, even sometimes a 4 drug. So, and if you ask the doctor why you give me ACE inhibitor, I think he don't have an answer unless you have like diabetes. He says that it can control both. And otherwise, if you have hypertension and heart failure, they will give you thiazide and it will control both. But otherwise, it seems to me that this hypertension like syndrome, so it we need to go further in the pathogenesis of hypertension to know exactly how we treat it, because as I said, anyone had like 2 or 3 drugs, and even if you ask anyone, any doctor, why you give me this drug, he don't have an answer. And if you ask him why it is not controlled, he don't have an answer. And if you ask him, is it secondary hypertension? Sometimes he don't have an answer. Sometimes he will say, we can go further to investigate if there is an answer. But if it is essential hypertension, still he had like 2 or 3 drugs, or even 4 drugs. So I don't know if anyone have any idea about this issue.
Thank you, Osama, for your suggestion. Did you mean we should talk about pathogenesis of hypertension and link it to the pharmacotherapy and how it works?
Yes.
Okay, if Dr.
No, not like that. Not like that. Sometimes the pathogenesis is confirmed and it is known for hypertension. But if you have hypertension and I give you thiazide, next time it is not controlled, I will give you ACE inhibitor, calcium channel blocker. If you ask me why you give me this drug, I don't have an answer for you. If you are a patient, I'm a doctor. That's what I mean. You know?
I got your point.
Yes.
I guess we should go deep in the adherence of the patient. We should confirm that patient have the optimum dose in the right way. Then we can go to resistant hypertension, and it can be, we can have patients with resistant hypertension. And at this stage, we should investigate for secondary hypertension. If we ruled out his non-adherence or patient non-adherence. I don't know, Dr. Nadir may benefit you more. Thank you for your addition.
Thank you, Osama. Thank you, Melas. I'm going to share with you this slides. I also shared the link. It's a PowerPoint slide presentation. So, sorry, Lubaba, sorry, Melas. I'm supposed to send you this to use it as a sketch for you to discuss. And you did a great job, by the way. So you got the updated version. This is about the hypertension in geriatric. So I'm going to just, so it's a big file, about 40 slides or so. I'm not going to go through all of them. But in general, the approach is the same, the way that you mentioned. Both of you, we approach non-pharmacological first, and then we go for medications. And the important part is follow-up visit and education, and remember the history. You focus on the adherence part. You went over all this, but in geriatric, most of the time, your target might not be as controlled tightly as far as the numbers, because in the past they said the systolic blood pressure goes up as we get older, but this was changed. So the guideline itself can change down the road. In discussing this part or this topic, what I want from you is when you start the residency, you're gonna see patients in your clinic family medicine or internal medicine. If you are going to pediatric or psychiatry, neurology, maybe not. But you want to update yourself with the current guidelines as far as what number exactly, what patient diabetes, for instance, their numbers might not be as the general population. Then if you are dealing with pediatric patients, then you want to go slowly. You want to increase the dose slowly. And if you want to add more medication, you want to add them slowly. You want to monitor them, as we mentioned. You don't want to cause harm. Medicine we use harm first. So you don't want to be the problem maker. You want to solve a problem by giving more trouble. So you want to go slowly, adding one medication at a time, monitor closely, make sure they are taking it, and then if you want to add more or increase the dose, you can go that route. You don't want to excessively control the blood pressure in this population, basically. Then when you are controlling the blood pressure and everything is normal, everything is at target for you, you want just to monitor and follow up. Continue to educate the patient about the risk of things happening. Sometimes, as we mentioned, they may get fragile or the frailty comes into the picture. So if they don't drink, for instance, and they are on diuretics, they may start to have the low blood pressure issues. So you want to consider that as far as education. So this file, if you have time, you can go over the details about what medication, what group, geriatric. The last point I wanted to share is a summary. So basically, it's an important issue, hypertension and the treatment of hypertension, to modify or prevent major problems, heart attacks, stroke, and so forth. You try the non-pharmacological approach first. If not, then you try some medications according to the guidelines. Some patients may benefit from the medication that you are giving, some may not. So you want to judge, see what the benefit of adding new medication, or changing the medication, or increasing the dose to the maximum. So you want to see which approach benefits this patient in front of you. And this is supposed to be patient-centered. You cannot give yourself a general approach like every patient, if the first medication not working, then I will add the second medication. It's not like that. So you want to modify your approach according to the patient in front of you. Thank you.
Thank you so much, Dr. Nadir, for sharing this great information with us. Also, I have sent the article in the chat box. I'm not sure whether we can take a look now, or maybe we will make it by the end. So this is the article for HOPE study. Do you think, Dr. Nadir, we should discuss it now, or?
Let's do that if you have time.
Oh, okay, so I can share the screen with the article. We can see also the conclusion. Okay, can you see my screen? Or not?
Yes, yes.
Okay. So here is the result of this study. The results show substantial benefits in mortality and morbidity from the use of ramipril in a large group of subjects at high risk of future cardiovascular events, also unusually clear and consistent, and were achieved on top of current conventional treatment. So maybe we will skim on this. Such patients are common in both general and hospital practice. So this, like the author would like to like shed a light on the generalizability of their study. These results should greatly extend the use of AC inhibition to wider group of patients, not only those with left ventricular dysfunction, hypertension, or diabetes with albuminuria, for which AC inhibitor is already proven, but to those patients who are currently given prophylaxis with aspirin, as were most of the whole population. So maybe we'll see the whole population characteristic. Preliminary analysis of the whole data suggests this will be highly cost effective. It is clear that current recommendation for the use of AC inhibitor, which focus mainly on vasodilation and or ventricular remodeling, should be broadened. Yeah, I'm great fan of AC inhibitor, like in general, I love it because of its benefit to prevent kidney injury in diabetes and other population. Any comment on the result of HOPE study from anyone? And I share it with the chat if anyone would like to dive more on it. Let's see. No one raised hand, so we can also proceed to the next topic. So I would like to share my screen so we can discuss the article shared by Dr. Nader. Can you see my screen now?
Yes.
Oh, thank you. Okay. So the article talk about it's a randomized trial of intravenous alteplase before endovascular treatment for stroke. So if you had time to review the article, we will go question by question from the CASP form. So the first question, did the study address a clearly focused issue? Please feel free to unmute yourself or just type the answer. Maybe I cannot see the chat. I will try to open the chat also. I don't know how to do it. So I will just proceed for the answer. Yes, the population study, it was randomized trial involving European patient, international multicenter. So if you remember during your reading in this article, mainly they have multicenter. So it was like clinic based and they collect their data from there. So when we are talking about the risk factor study, they were searching the benefit of intravenous endovascular therapy, so EVT, with or without alteplase for acute ischemic stroke.
Hello?
Yeah, sorry. Yeah, Dr. Nader. Okay. So the next question, is it clear whether the study tried to detect beneficial or harmful effect? Yes, the study tried to detect the beneficial effect of adding EVT to the protocol. What was the outcome? The outcome, functional outcome on modified ranking scale. So they have different outcome. The primary outcome was the modified ranking scale, and they have secondary also outcome. Okay, the next question from the CASP form, was the cohort recruited in an unacceptable way? Yeah, in an acceptable way. Yes, a randomized experiment would reduce variety of bias, like confounding. So when we answer the question, we would like to see, is there any bias in recruiting the participant? First bias like confounding bias, but no. there is no, like, they shouldn't be any confounding because it was randomized clinical trial. Also, no patients were lost to follow up. The demographic and clinical characteristic of patients in the two study group were similar at baseline, except for few cases of atrial fibrillation. So like the intervention group and control group were similar in their demographic and other clinical characteristic. But there is a generalizability issue. Why is that? Because the period of the onset of the stroke and the arrival at hospital was rather short, which limits the applicability of our finding to care setting, where the wait to hospital arrival is longer. So when they did this research, usually the waiting time was short. So if they want to generalize this research on the general population, there is limitation. Why? Because the waiting may be longer. It may be difficult, but different by the country, even in the same country by state. So this is not like, there is limitation in the generalization. So randomization was carried out using web-based method. Permuted blocks stratified according to center and if they were part of multi-center approach. So first, many of the participants are based on multi-center approach. Also, they was a randomized trial of acute stroke treatment in ambulance. This is another trial, but they recruited some participants from this trial. Was the exposure accurately measured to minimize bias? So I cannot see if anyone in the chat answer one of those questions. Please, if there is any question, unmute yourself. The primary endpoint data was gathered via standardized telephone interview conducted by qualified research nurses who were not aware of trial group assignments. So this is good because this will eliminate bias. So blinding is mainly the blinding. So it eliminates bias and misclassification, exposure misclassification. Independent committee adjuncted major adverse event reports and primary endpoint data based on the interview reports. The member also here unaware of the trial group assignment. So both are blinded. Was the outcome accurately measured to minimize bias? So here, not the exposure, we are discussing if the outcome was measured to minimize bias too. So the primary endpoint was functional outcome on the modified Rankine scale. So range from 0 to 6 at 90 days, plus or minus 14 days. And I'm confused on this part. I will pause a little bit so we can discuss if this is minimize the bias, subjective or not subjective. After randomization, analyze for superiority and then for non-inferiority. There were 8 secondary endpoints. This is in page 3. I would like to hear from you. Is it subjective or objective? I will change the share screen to show you the article, and please let me know, do you think it is subjective or objective? Because I'm confused on that. Sorry for the delay. Can you see my screen?
Not yet.
Not yet, okay.
Mhm.
I will try to share it again, just because I was confused while I'm doing the answer, whether this is subjective or objective, like, so if there is bias in the outcome result. So, yeah. So can you see my screen now?
Yes.
Okay,
Mhm.
so this is the 8 secondary 8 points. And if you see, I just will highlight so everyone will know we are in this point. So if you see, like, it is the secondary endpoint, like recanalization and the ETIC score. And most of it, like, it is done by CT, MRA, or the MRI. So I was confused whether I could, I would like count it as subjective or objective, because if it is like subjective on the provider who read the CTE, so this is like could be providing bias on the outcome. So is anyone like understand what will be?
Let me jump here. Thank you. That's really deep thinking of you. I'm just wondering where the providers know about the study, or they are blinded. So I think
yes, the provider doesn't know about the names, maybe the participant, and the group assignment, like if there is if they are intervention group or control group.
So I don't think there is any kind of subjectivity in that. So the provider, they don't know. So they're just providing the, for example, in the CTA and MRI, and they were just providing the report for what they're reading, right?
Yes.
Yeah, I don't think it is considered kind of bias, in my opinion.
Yeah, I think, yeah, your talk was like makes sense. So yeah, thank you, Lubaba, for clarification of this point.
You're welcome.
I will reshare. Sorry for the delay. Okay. So our next question is, have the author identify all important confounding factors? Yes, like I can't tell like if there is no other confounder other than this in this study, but they adjust for many covariate like age, baseline NIHSS score, collateral status, pre-stroke score on modified ranking scale, and time from symptom onset to randomization. So they did great job to adjust for all these confounder. The data for the main covariate were missing for 7 patients. Also, this may be a limitation, but I think this number is not a lot. Have they taken account of the confounding factor in the design or in analysis? So yes, they did that. They account for confounding. During design, they made randomization, and we know that if we want to minimize the confounding effect, we can do that in like many levels during our research. So during design, we can do randomization or matching or control. And during analysis, we can make like the regression. So like other regression, like multiple linear regression, it can adjust for confounding. So so they did great job in minimize the confounding effect in this research. Was the follow-up of subject complete enough? So the subject were followed from January 24, 2018 to October 28, 2020. So the effect of AVT had long enough to reveal themselves if they have like good outcome or bad outcome. So I think like the follow-up for the subject was complete. If anyone have another like opinion, please feel free to unmute yourself and give us your thought. And also no loss of follow-up, which was good. What are the results of this study? So the result was like EVT alone was neither superior nor inferior to intravenous alteplase followed by EVT in a randomized trial involving European patient in terms of disability outcome, 90 days following stroke. The two groups had equal rates of symptomatic intracerebral hemorrhage. So this was the conclusion from their results. How precise are the results? So EVT with alteplase was 0.84. The 95% confidence interval is 0.62 to 1.5. P is 2.28. So what do you think? Is it precise or statistically significant or not from looking to this confidence interval?
No.
Yes. Yes, I agree. It's not statistically significant because 95% confidence interval cross the one, which is a null value. So yeah. Do you believe this result? Yes, I cannot tell anymore after their great effort. So yeah. And also maybe this because the research is on European, maybe there is difference because also there is in Asian group, there were another statistical significant decrease in rate of complications. So maybe different by race. So we can dive more on that by doing some research on other racial difference after using EVT. What are the implications of this study for practices? So this, I didn't answer this. I just would like to have interactive answer for this question. And that's the end of my presentation. Thank you so much.
Thank you, Sulafa. That's really extensive and nice way of doing the presentation and answering the questions regarding this article. In terms of applicable to the last question, to the practice, I doubt. So since it is not statistically significant, in addition to no superiority over the already used medication. So unless someone else has any other opinion, in my opinion, 2 years is not enough to conclude kind of similar study. People interested in neurology kind of, please give us your input. This is my, yeah.
Thank you so much, Lubaba.
You're welcome.
Yeah. Mm-hmm. Thank you. This is informative comment. Okay, Lina also agree with Lubaba. Any other comment? Oh, I didn't see the hand raising, sorry. Okay. No one raised his hand.
Thank you so much, Dr. Slafa, for this great discussion
Thank
and
you.
analysis for the article. So the idea, as you mentioned, or you went through the steps, so we want to analyze if this article is beneficial for us. Can we get some information that we can apply to our patients and get the benefit of this article, or it's not beneficial and then throw it away. So thank you so much.
Thank you, Dr. Nader.
Any additional questions to Sulafa? If none, then we can go to the next.
Okay. So we have now the interview, and we'd like to be interactive. So please, it will be like panel interview. Please feel free to jump and ask Dr. Dr. Ali, whatever question come in your mind.
Go ahead, Subaba.
Yeah, I don't think Ali is in the meeting.
Oh, okay.
Sorry, Sulafa. Ali sent a message, the WhatsApp. He said he cannot join us.
Okay, so any volunteer to be the interviewee?
He apologized. Thank you, guys.
Yeah. Okay, it's okay. So anyone can jump
Any
in.
volunteers?
So we can take it as an opportunity. So if someone wants to be take the advantage, please come forward. Dr. Al-Wali, do you have any questions? Okay. So why don't we discuss some of the, maybe some of you got some interviews, some of you had already interviews, or maybe you have some tips or skills that you want to share or you find out maybe useful for yourself. Can you share your experience, or can you share your tips with others? I think it might be beneficial for all of us. Go ahead.
Yes, I agree. This will be a great idea. So we'll have hand-on experience now.
So anyone had an interview in the last couple of weeks? Just share with us your experience, like how did that go?
Yeah, what question, what unique question they did ask?
I know some of you might have interviews coming, but
okay, I have another idea if no one is interested in volunteering. How about discussing in general, like how we answer the questions? For example, recently I'm doing kind of a mock interview. I came across people that trying to, for example, tell me about yourself, starting from what they are doing currently. Like, for example, Lubaba, I'm doing a Telegeriatric research fellowship at Michigan State University. Previously, I was doing so and so and so. So I want to hear the people like feedback in this kind of approach and presenting yourself. For me, if I am an interview, I want to hear the story backward, not backwards, like from the beginning, what you have been doing and from where you are and how do you came this far and what interests you in the field that you are applying for. So I was just wondering if any one of you guys practice with other people presenting themselves this way and what you think of that. I think your voice is breaking.
Dr. Samah, your voice is breaking. Yeah.
Oh, sorry. 1 second.
That's okay. Try again.
How is it now? Can you hear me well?
We hear you, Sama.
Okay.
Yes.
So yeah, I said that I have opportunity to do mock interview.
Samah, you are in and out. Your voice is coming and going. It seems your voice is breaking down. So maybe the mic or some technical issues.
I think she's trying to rejoin.
Yeah. In the meantime, any other input
Yeah.
from others? Anyone tried this data like the past couple of weeks? Any feedback from the groups?
I think we lost some. Yeah. So what do you think, Dr. Nader, in this kind of way of answering, tell me about yourself. So, and I hear that like some resident advising this way of presenting yourself.
Yeah, there is no right or wrong answer. It's like watching a movie. Some movies start from the beginning and go to, and sometimes some other movies start backwards. So, I think maybe it's a good idea to start backwards. The important part, if you're going from back or from front, it doesn't matter, is to highlight yourself, as you mentioned. So I'm doing this, and if you want to highlight some of the keywords, so I found this interesting, I found this informative, I learned a lot, something like that, along with what you are doing or what you did. So that might highlight some parts. And I think they know you from the CV, your application, or so they know the nitty and gritty, like you did this in this institution, you did this in practice. So they don't want you to go over your CV as much as they want you to tell your story in your words. One thing they want to know is your speaking skills, so communication skills, because they want you to express yourself. If you are able to express yourself in your story in a meaningful way to them, that means when you're seeing their patients, they will trust you communicating with the patient in a good manner or understandable manner. So focus on how you can impress them with what you did as far as what you learned, focusing on using words that meaningful or
capturing their attention.
Yes. If you want to highlight certain parts, this is the way or the opportunity for you to highlight these parts in your CV or your things. Yeah.
All right, thank you.
You're welcome.
Thanks.
Azza, go ahead.
Yes, thank you, Dr. Nader. Thank you, Lubaba and Sulafa for the presentation. Thank you, Lubaba, for bringing up this idea. I think I agree also with you that for me, I would start from right now what I'm doing to keep it engaging. And as Dr. Nader said, they already have your CV. So we will not need like to go through everything thoroughly, but in some videos, I believe that they also said that you can talk about yourself, your positive points, your strength points. Like, for example, say I'm self-motivated, hardworking, reliable, or something like that. Is that something that we can apply for tell me about yourself? Because a lot of times we will not be asked the question about our strength point or what is your strength point, but definitely we will be asked about tell me about yourself. So I believe it makes sense to me that for me, next time if I got an interview, I believe that that's what I'm going to do. I would talk about myself a little bit and talk about my strength or positive points, mix it up with my experience. I think to be in the safe side, so make sure the person who interviews you hears everything that you want to highlight about yourself. Does that make sense? Thank you, guys.
Thank you so much, Azza. I agree with you. The point that some of the interviews are really very like short and you don't have the chance to talk about everything. Sorry, guys, you were raising your hand. I just jumped in. So you are not getting the opportunity to talk about these qualities. This is another advice that I hear. You have to add these and what, for example, to add them in the experience, what you learned from it. For example, I'm doing telegeriatric research fellowship where I had the opportunity to exercise leadership qualities of me. And for example, communicating and working like in a weekly meetings, presenting, stuff like that. You have to inject these small things in the tell me about yourself. This way you will lead the interviewer to ask you specifically about these points, and then you will have the chance to tell a story about what you did. But this is really a good approach. But the thing that's talking about from what I'm doing now and going backwards, this is not the thing that I feel like I'm always distracted if somebody's telling me what you're doing now and then going backwards. I want to hear your story that is not in your CV, for example, is not in your, because some of the interviewer ask you directly, tell me something that I don't see in your application. So I think they are interested in your human kind of or a non-professional life in addition to what you did in your professional. But thank you so much, Azza. That's a good point.
Totally agree with you both, Lubaba and Azza. This is really what I think you can approach it, and feel free, be comfortable with the way you want to answer the question. Again, there is no right or wrong way of doing things. Put in mind what they want from you. They look for, as you mentioned, the other aspect of you that's not written in your CV. They want to know how you gained the qualities that you mentioned. You mentioned leadership. So if you join that with your practice, or maybe you can mention teamwork. We work as a team, and I was lucky to be the leader in that team, and we published this and this. Something like you want to highlight yourself, sell yourself as the quality that you want to mention. If you want to join that with some of your experience, that might be a good option. If you want to list them all, that's also an option. You want to talk about your family, that's an option. You want to talk about your other curricular, extracurricular, or hobbies, that's also part of it. So don't stress yourself as far as how you do it. focus on practicing, and whatever you feel is easy going for you to be smooth, that's what matters, because they want to know your communication skill as well. You practice on your body language, you practice on looking at the camera, smiling, all these factors in. And to tell you the truth, I don't think they are interested in the nitty details of the actual things that you mentioned, because they already looked at your application and you are fitting their criteria, basically.
Hello, I'm sorry, you are muted.
I just noticed Samah is back. If the voice is clear, you can give us your feedback, Samah. Thank you.
Can you hear me well now?
Yes.
Okay. So yeah, the thing that I said is I have opportunity to do mock interview with someone she matched this year in internal medicine pre-match. So she told me that they asked her, tell me about yourself in form of your experience. So I think in these questions, they need us to omit the personal part, just to start from the experience part. But I don't know exactly what will be the answer for tell me about yourself in a form of your experience. Volunteer experience, or as you said about, we start from the experience that we are doing right now, or what they mean exactly. She told me that she started experience from the beginning, and she went through all her journey till now. That's what she did. So look, will be the right.
Thank you so much, Samah. That's actually what we're talking about. I think, yeah, tell me about yourself through your experience. So that's, yeah, maybe for me, I understood that they wanna know what I get from all of the experience that I did. So yeah, I think this is the same thing that we are talking about, but you never know how many ways they're gonna ask you about, tell me about yourself. So
Yeah.
Thank you so much, yeah, thank you.
Welcome.
Mm-hmm.
Any other questions that you think we can discuss as far as the interview? Some other questions, Samah, your friend might have.
I have a question in the interview. I'm sorry because maybe I didn't practice interview for a while, but I remember there is some like don't do. So in the question about sometime the panel, or most of the time, they will ask you, do you have any question for us? So there is many don'ts in this one. Like, don't ask a question that already posted in their website. So if they have any information in the, like, we should have it like memorize it by heart for any interview we are going to. So we should memorize their website by heart. No asking question about anything mentioned in their website. And if please, if anyone know what other don't we should not ask in this question.
So maybe let me put it this way. We have about 20 something now. If any one of you wants to add in the chat box, maybe a couple of questions you want to ask, maybe you can practice just asking the common questions in your head for a program. Let's say now you are in front of a program director and we are interviewing you, and I ask you, every one of you, do you have any questions? Don't say I don't, but say I have a couple of questions. So what couple of questions do you have can you write them? Every one of you write a couple of questions in the chat and see. And then we can discuss how to answer or how to modify or whatever.
Lena mentioned salary, and I agree with her because I had interview before 3 years or 4 years in one of the biggest facility here, like biggest hospital here, for abstractor job. And I did ask them about their insurance. And when I go from my interview and I told this to one of the American friends, she told me never ask about any benefits during the interview. But fortunately, they hired me, and she said if they don't want you, they won't hire you with this question. So yeah, no benefit, no salary question during this interview.
I'm going to jump in as usual. Thank you, Zulafa, for bringing the don't ask questions and the part of asking question as well. So from what I hear, that there is some of the program directors actually, when they meet with you, they don't ask you questions. They will like, especially with the era of the Zoom now, they have every program, they have a small kind of video introductory for their program. And they assign this time for you to ask them questions. Can you imagine yourself going into an interview for like 10 minutes, you are expecting to be asked. They will start right away. They don't want to hear about you or anything. They read your application, they know you from the application, and they were just like there for you 10 minutes to ask them question about their program, what other things that you want to know from the program director regarding their program. And they already posted a video there and the website is there. So that's really emphasize the importance of like memorizing their website and going over the website and trying to figure out some questions, and really kind of questions toward the program directors, not toward kind of residency resident when you are talking to a program director. So it's adding more to the challenge of the interview. That's a good point you reminded me of. Thank you. I think there is questions in the chat.
Mm-hmm. Yes, how your resident and your program handled the pandemic. So can you clarify, Ala, more about your question, please? So do you think this would be from do or don't? Like you will ask this question or no? Do, okay, that's great. Yeah, this is great question, Ala. Thank you for sharing this question, because they will know that you are just interested in their program and handling during the epidemic. And Mohammed, sorry, before Ala, also there is Mohammed Ibrahim asked about, tell me about a weakness in your application. He wants to know how we approach this question. And he also asked what kind of thing I have to avoid in answering this question. Anyone would like to handle this? Mohammed Ibrahim, Dr. Mohammed question. Amna also, Dr. Amna asked, where do you see yourself in 5 years?
Come on, guys. We're all preparing for the interviews.
Yes.
I remember the answer from Mulham last time. So tell me about weakness in your CV. He said that I will mention my source. For example, for Mulham. And then he said, don't focus on your weakness. Try to focus on the ways that you can improve this weakness. So he told us that in his situation, he said, from that experience, I learned that next time I have to focus more on how I can get high scores by searching for the good materials and asking the seniors who have the same experience. So before going to exam, I have to look for a time for how I can reach the high scores. Yeah, this is what I remember from Mulham the last time.
Great. Thank you, Samah. That's so informative and helpful. Yeah, thank you. Dr. Ala added also, you have to show you how you overcome your weakness. So this is a question from the panel, Ala, right? And you have to show them how you overcome your weakness. Okay. Thank you, Dr. Ala. That's so helpful.
Yeah, usually it's multi or it's more than one aspect when you answer this question. So let's say I'm a shy person. So you are not gonna say, oh, my weakness is being shy, or I don't want to do this, or I'm inefficient or some. You don't focus on giving them the word that they want, like your weakness, as one sentence or one. Make it in a form where you want to mention some at the beginning, let's say the being shy or some, but mention another part, another third part. So the other part is you want to add something to that, and the third part will be how you improve on that, what you learned from that experience if you get into experience. I think Samah mentioned it in a good way, referring to Mulham. Let's say one of my weakness, I did not get a high score or in step one. So this is a red flag, basically. But you don't want to focus on that as an answer. You want to follow up with other part of the question, your answer, to include what did you do, what's your plan to improve, and how you do that. In one of the meetings previously, one mentioned slow, let's say, put it in my words, I'm dealing with patients, let's say, can say detail-oriented, which makes it harder to complete the task time. But during my fellowship in, let's say, geriatric or other experience, I learned that when I have a project or when I face a task like seeing a patient, I need to divide the steps into small tasks. And by finishing all these tasks, I'll be efficient and I will meet the goal and I will take care of my patient in a timely manner. When I apply that to my experience in this setting, I found it very useful. So being efficient is one of the criteria that I come up with after finding out my weakness, something like that. Thank you.
Thank you so much, Dr. Nadir. Yeah. Please, Amna, feel free to unmute yourself.
Hello, everyone.
Hello.
So I remember a question that I was being asked last year, that if you become our resident, what difficulty do you think you will face? So I answered this question that I don't have an US clinical experience and I don't have an exposure to medical health system. So I mentioned this difficulty. So I don't know what else can be the answer. But the question is, what difficulty you will face if you match at our program? Thank you.
So one of the things that you can mention, and this will apply to all programs nowadays, is the electronic medical record. So you can mention that if you don't have an experience with EMR or EHR, is that this one of the things that you will be asking So your answer will be something like this. One of the difficulties that I see I will face is using an EMR that I did not use in the past. My question to you is, what EMR do you use, and how long is the training? Because most of the resident program will accept you and they want you to start mid-June, so that it will be like two weeks for orientation. One of them will be how to orient yourself with the system, the EMR system. So you will say, I want to find out what EMR you are using, and my plan is to work hard so that I can learn more about this EMR. So by the time I join your program, I'll be ready. This might need some training, and I understand that you will provide this training. So I will be working hard to start with the speed that I need, seeing patients and not being delayed by using the EMR. So I think that one thing you will face as a foreigner who did not practice on EMR in the US, unless you are in a system where you have been exposed to different EMR. Even if you have an experience with some EMR, certain programs use different EMR. So I think this will apply to any interview. When you ask about what problem can you face, just mention, I know you are using type of EMR, and I know I'm gonna get the training, so I will be working hard to overcome this roadblock from the beginning, something like that. Thank you.
Thank you so much, Dr. Nader. Lubaba, please feel free to unmute yourself.
I'm sorry, guys. Thank you so much, Dr. Nader, and thank you. This is really tricky question. I feel like, in my opinion, I really like the idea of the EMR system, but for us, like IMDs, they've been here, and maybe, clearly you don't have the US clinical experience, and maybe that's why they ask you this question. EMR is a good example, but for me, I think I'm going to use this answer actually to show them how I am adaptable to whatever that I come across, and I feel like there may be like some difficulties that I foresee, but I had experience in so and so and so, and I was transitioning smoothly in these experiences. In addition, this is an opportunity to praise the program itself. Each of the program, they talk proudly about how they support each other and how the attendings are available. So you can tell them, like, from my interaction with the residents, I understood how the supportive is the environment here, despite this thing, but I am feeling like I will be easy to transition here. And an EMR, as Dr. Nader mentioned, for example, I will start learning right away about it and to be competent and efficient when I join you. But this is really tricky question, and thank you so much, Amna, for bringing that up. Anyone else had the idea?
I want to add something for your point, Lubaba. For Amna question. My friend matched the previous year, and we were talking about this question, how to answer this question. And she mentioned her personal opinion. And she told me, it makes sense for me, but I don't know, still it's a personal opinion. Told me, don't highlight anything can be taken as you will have difficulty to communicate well to the BD or anyone in the program, and don't highlight never ever any you will face any difficulty to understand the cultural difficulties, and you should use this all the time as a positive point. I'm able to do this, I can do this, I will, but don't make it a negative point, or don't make it one of the weak points, because already they have the obsession of this IMG will not communicate well, will not understand the cultural diversity, and like this. So don't give them something negative. They are searching about it. So it makes sense for me. If I will be interviewed, I will not mention I will have difficulty communicating or this is new culture for me. I will show them, um, as you said, I'm adaptable person. And I tried. I have no US clinical experience, but I saw resident and I have friends. I have something. You have to show you can communicate easily and you can involve yourself in this culture very easily. Thank you.
Thank you so much, Melaz, for your comment. Yeah, it's so helpful, your friend experience. Thanks a lot.
I want to add something. Sorry, I did not see the raise button.
No, it's okay, Somi, go ahead.
Yeah, this is a very good question, and this is a kind of a challenging question, I feel, for all of us. And this answer should be unique for based on the people's situation, such as Lubaba and me. We cannot answer like that we do not have the EMR experiences, as we are already IMG, but we are still working in a US health system, and not as a physician, but as a researcher. So we have a vast experience of EMR, but I think I would suggest, if in my case, probably I may able to answer something like, yeah, we do not much have that probably because we have to see a lot of diverse population in a everyday basis, but we did not have that experience like direct clinical experience at hospital. However, as I'm working as a researcher, I do every day, I observe my colleague, my supervisor, how to communicate with the people, diverse group of people efficiently. And eventually I am trying to learn and I'm adapting that. And I think that experience would be helpful when I will be joining here. Or also if the program is based on the underserved population or something. So we can also mention that as from back home where I did a study and I did my internship or my residency, I did have a vast experience in working with the underserved population, and I can see these programs serve a underserved population, so that experience might be helpful. Something like that. Thank you.
Thank you so much, Sumi. Your comment so great as usual. Thank you.
Amna?
Yes, I actually have a question that for us as a female, is it a negative point that if we mention that we have kids and so on? Because in my personal statement that I wrote that I had kids, so my friend told me that no, you shouldn't mention that at all. So I'm asking, is it a negative point? In my opinion, I don't see it as a negative thing.
I want to answer and I want to jump this question because I faced that question, couple times in the interview, and I can guarantee you it is never a negative point. I am not sure whoever mentioned that to you. Very often, not only in IMG, most of the AMGs, while they are on residency, they are most of them almost started a family or they already have a kids. And as we are female, this is our I think our primary duty also, being a mother. And this shows that how dedicated you are, that you are taking care of your family, child. At the same time, you are able to pass the exams and came to this far. And you are a multitasker and you are a responsible person. While I was talking, I think last year in an internal medicine interview, and I explained in between that I raised my daughter literally alone, and I mean alone means with my husband, not much family support from back home, and also I was able to pass and all this, whatever I accomplished. And the associate program director was also a female, and she said, well, I can imagine how much, I don't think so if I, as I told that I graduated from Bangladesh, and then she said, I can imagine myself like how difficult it would be if I transition to Bangladesh now and I have to take the all MBBS qualification exam at the same time. I have to adapt the cultures and then, you know, raise my kid on my own. I truly salute that how you all are doing those things. So I can see her face, and her expression was, you know, it was genuine. So, I mean, I think this is a good thing. If you have an opportunity to mention that, we should mention that instead of hiding this.
Thank you, Sumi.
Yeah. Thank you so much, Amna, for the great question, and Sumi for your answering this question. Thank you.
I just want to add regarding that. Thank you so much, Somi. That was a really great answer. And I love the wording of our primary duty of raising our kids as well. However, I think from what I felt actually, I've been through the same, and I am raising kids while studying and doing the exams and applying and everything. But I think the piece that they need to know that you do have a support system. If you are not having the support system, you might not be able to carry the task for the residency. Imagine if you are on call or you don't have someone to cover your shift and your child is sick or your child needs something. Yeah, I think this is the nature. This is what my personal opinion. Yeah, we are multitasking people. Our stories are great, but if we are not going to perform the same level of people without other responsibilities, I think we fell short. So the most important thing that we need to mention, and this is someone advised to me as well, that I do have the support system. Without the support system, I'm not able to do anything. Because at the end of the day, we are human beings. If you are the one that are responsible of the child and the child is sick or the child have any other issue, you are the primary, as you mentioned, caregiver for this child. So it's the most important thing to mention that you have the support system. And I am with the people that are saying that don't mention it if you didn't get if you are not asked about it directly. But it is a personal opinion. But it's a great thing that we are mothers and fathers and having other responsibilities and being able to come this far. Thank you.
Thank you, Lubaba. Thank you, Sumi. I think you covered it well. And I think one part is you want to show yourself that you are proud, in your case, mother or father, and you can do the multitasking. But at the same time, you have the support. And one of the things that you want to highlight that you can mention it to the program that I found your program supportive, and I can put, if your child is under 5, you can say, I looked around for daycare around the area and I found good options, or I found your area to have good schools for my kids. Something that you show that you did some research around that program, that you cared enough about that program. Not only you want to defend yourself, your mother, so, but also you want to show them that you are interested in their program to the degree that you are thinking about your family and the support or the community that you are going to live in while you are doing your residency. But thank you. That's a good point.
And also, I want to add a little bit things. I think it's as Lubaba mentioned that yeah, it's good to mention that you have a support system. First question, it will come ultimately that for me, like when I went for the interview, why I'm in Michigan. So, you know, like that's the question. So I explain as this is an automotive city and my husband is a mechanical engineer. So I'm just, you know, everybody's story is unique. So I'm here today because of that. That brought me here in Michigan. So, you know, even you can mention to about your significant others, like, oh, I have like, you know, he has a flexible job, or he can take care of the children, something like that. So they are assured that, assured that you have support system. Another good thing also, like, I think it's a balance. Nobody, because you are going to working with them for next 3 years, even some of the cases probably more. I mean, beyond residency and more, who knows, probably you might be hired for their faculty or something. So everybody wants to, work with someone who has a balanced life. So it's having a kid and having a family, it's a, means that you are able to balance your life, work and life and everything else. It's not, you are not only focused to your career, you're also focused to your family and, something else, and you're thinking about everything else. And that's how you, as a good person, like, that's how you become a good human being, and you'll be able to take care of a patient in a different way. When I feel like, I'm not like disputing it, but it's, of course, like, I think it's when you are a mother, we learn so many things being a mother also. Of course, there are so many fathers here as well, same story, but everything together, it shows that you are a balanced person. Also in between the conversation, there was a question that what challenges I face, throughout this journey. So when I was telling, it was truly difficult managing everything, but and then at some point, I think one of the faculty asked that how are you open to learn from others, from your peers, or from your like, even some of the resident probably junior to you, or some of them will be senior. So how would you take that option? So, and that questions I answer like, I'm open to learn from anyone. And when it comes with learning, I think like it is always good to learn from any, regardless who is junior, who is senior. And everyday basis, I'm learning from my daughter also, because when I teach her some other stuff, she taught me how to pronounce in an American accent. So, I can see that the expression they faced, like, it was a genuine, and they like that the way I explain. And it's basically true a story. I mean, I know that there are a lot of parents here, and eventually when they started going to school, we still have, we still did not adapt. We don't adapt American accent 100% or completely. So, she reminded me so many times, this, you have to pronounce like that way. So, it's like you can connect in a different way your story to show them that, you how you are and who you are. So that all that all it matters, I felt, as a in a candidate whole, as a whole. It's not only we are here to, we are only physician. We also balance our life in different ways, and that's how that type of candidate every program likes. Nobody cares if you get like 270 and your step one score is 270. That is not going to help for their patient care, I guess. Like, it depends, like, as a person, as a whole person, how you are doing or who you are, something like that. I mean, that's, of course, getting 270 is a good it shows that you are dedicated and you are meritorious. But when it comes to, when you cross that part, like when you are for interview, everybody is same afterwards. Thank you.
Thank you so much, Sumi. And I think one part you mentioned in your great tip is that they are looking for you to join their team to provide a good care to the patient. So whatever answer you want to give, I think you should end up with this part, that you will work hard so that you can offer a quality based or the patient deserve, like the treatment they deserve. You will learn hard so that you can offer a good treatment for your patients, or something, anything that you want to finish your sentence or your answer is what quality that you want to achieve, or you want to offer service that for the patients. So when you join their team, you'll be an asset or something useful for them, for their patients, while you are learning, of course. Thank you so much, everyone. Maybe we can talk about next week agenda if you don't have any questions. So Lubaba, I think you can join me here. I sent him a reply that he has sent you a link for a different meeting, Zoom meeting. So you want to join him? I will join with him later.
Okay, sure.
Thank
you.
I think Muhammad also.
Okay, bye.
Thanks. So for the rest of you guys, any suggestions for the next week? I suggested that Azza, if you are available, maybe you can lead the team for next week.
Yeah, yes, okay.
All right, so maybe we can talk about dementia next week. I will send you a link for the file. It's also on in the app. If you want to go to files, here you can see the list of files for anyone who wants to look at the GRS. So if you just put dementia, it will show you one of the files here, but I will send you the link. This is a GRS dementia slide file for anyone who will be presenting, maybe a couple of you. You can divide the file into two sections next week. Also, if you want to talk about maybe Dr. Ali, the interview, mock interview next week, if he is available, or someone else from you or from your team can do also an actual interview so that we can take feedback. Any other suggestions? Anything you want to learn? If not, we will keep it that way. I want to update you guys with good news. So we, as far as the projects so far, we have submitted 3 abstracts to AMDA yesterday or the day before. So hopefully we will hear good news if they accept any or all of them. We are still working on other projects. So if anyone of you or the one who will look at this video later, if you are interested, let me know. I will join you with someone to work on different active projects. We also have good news that 2 of the abstracts that we submitted in the past and presented will be presented again the Psych Winter Conference. So it will be a good option for people to present and to put on their CV. I think Mohammed is going to present, and then Sarah maybe or someone else from the team can also present there. I want to thank you all for your hard work, and I wish you all the best. Thank you.
Thank you so much, Dr. Nader.
All right. Pray for Sudan. Thank you. Assalamu alaikum.
Okay, thank you.
See you next week.
Thank you, everyone.
Okay, thank
Have a good night.
Thank you.
You too.
Thank you,
Bye.
everyone.
Thank you.
Thank you.
Bye.
Assalamu alaikum.
Bye. Assalamu alaikum.
Thank you. Assalamu alaikum.